we have had a lot of evolution in the field of preoperative and potentially post-operative therapies, not just for targeted therapies, but for immunotherapies in the last few years. One of the popular approaches that has been adopted in many places is preoperative chemotherapy combined with immunotherapy. We have a trial called Checkmate 816 that gave 3 cycles of chemo with nivolumab or Opdivo that was FDA approved in spring of 2022 and has been widely used. But over the last 3 months, we've had multiple trials that use what's called a perioperative approach. And that is, if neoadjuvant is what we refer to for preoperative and adjuvant is postoperative, perioperative means alongside in both ways. It's you get it pre-surgery and then post-surgery. This was a trial with Keytruda, pembrolizumab, or placebo added to a chemotherapy backbone for patients with stage 2, 3A, or 3B non-small cell lung cancer. So kind of potentially at the outer edges of what we would consider as resectable. But these patients got chemotherapy with placebo or immunotherapy, nearly 800 patients. And then after that preoperative therapy, they went to surgery. And if they were on the immunotherapy arm, they got a year of Keytruda afterwards. And the placebo arm or to finish out a year, and the placebo arm got that instead. So one point I'd make is that this is in a research environment, and a lot of patients who were screened were not felt to be great candidates. I think we need to be mindful that we don't broaden too much, that these were still heavily scrutinized patients, and more than 40% were not felt to be well served by this. And even with that screening, 1 out of 5 patients who started this and were felt to be resectable didn't end up going to surgery. And so I think we need to be mindful of that risk, that we don't want people who are waving in everybody. That is not the goal. The goal is not to have somebody say you can go to the OR. The goal is to be a good candidate for surgery, and those are not the same thing. The benefit, they looked at event-free survival, which is very close to disease-free survival, but it starts when there's still disease to treat in the preoperative setting. So it's a little different, but looking for progression, looking for death, et cetera, and various unfavorable outcomes, including not being able to go on to needing to come off of treatment. And you can see there's a major advantage in the arm that got immunotherapy, Keytruda added to chemo at 2 years. The difference is over 20% difference, and this hazard ratio that we refer to, this HR, is the relative benefit. That's showing a more than 40% improvement in this. And when they look at overall survival, this trial was not mature enough to see big differences. You need to go out a long ways, but you can see that immature results, though they are, the trial suggests that there's a separation starting to occur. Even though this, what we call a p-value, we generally think of that as statistically significant when it's less than 5% or 0.05, but it depends when it's preliminary. The criteria are more stringent. So this does not meet that yet, but that doesn't mean it won't. It just means it's early. Another factor that's important in these studies looking at preoperative therapy is, how does the sample look after surgery when we look under the microscope? And we look for what's called a major pathologic response, which is less than 10% of the tumor is viable, living cells, and a pathologic complete response, which is no living cancer cells under the microscope. And in both of these criteria, getting immunotherapy with your chemo was associated with a very significant improvement in the proportion of cancer cells that are dead under the microscope, including a more than 4-fold difference favoring immunotherapy for pathologic complete response, no evidence of any living cancer cells. And this is associated with people doing better. We know that when you have no living cancer cells, it's probably not surprising that these patients tend to have a better event-free survival. Now, pembrolizumab, the Keytruda there, improves outcomes whether patients achieve that or not. But it's particularly good if you did achieve that.